Hello and welcome everybody to another interview for Dental TV, social media, wherever you're watching. And it's my pleasure to have last time I put you to New York, but you're from Boston because maybe not everybody out there knows the story about Miguel when he was visiting Switzerland and he was in Geneva and he was thinking that he can jump into the cab, visit my office, which is 300 kilometers away. So this is a funny story. And one day, I'm sure that you will visit my office, Miguel. So maybe just two words. You're famous on social media. You're famous around the globe. I follow what you're teaching. And I see that there are many things that we have in common. We have the passion for photography. We have the passion for CAD/CAM dentistry. We have passion for colors. So I think we can speak for hours about these topics. And Miguel, maybe a short introduction from your side. Where are you from? Why are you working in Boston? Because I know that you have Spanish roots. Don't I think that's right. You have Spanish roots. Why are you now in the US and not in Spain? And because a lot of people are now moving to Spain. So Christian Coachman moved to Spain. Other dentists are moving to Spain. I interviewed Nazari, who's actually living in Madrid. Basically, Madrid seems like a hotspot in Europe for dentistry, and you would fit perfectly to Spain. But maybe a short introduction before we jump into some interesting questions.
Alexander,
Miguel.
thank you for having me. Yeah, we had that Switzerland thing in which we had everything planned to get an interview. I was in an interview for Masters of the Craft, and as I was there in Geneva with Didier and with Francesca, I said, okay, I'll see you tomorrow. And he said, yes, where are you staying? I'm like, I'm staying here. He said, yeah, you're 300 miles away from me. And then we started laughing. And then we did it online. And then when you introduced me, to Miguel is from New York. And I'm like, no, I'm in Boston. And even now you say, why are you in Spain? I'm Argentinian. So I keep getting you. Now we're 2-1. Now you're losing 2-1 on this one.
Oh, no. Okay. But your brother
My
Ibiza
brother's in
is in Ibiza?
Yeah.
So you have originally
So
from Argentina. I
let
didn't
me
know
tell you
that.
how that goes. For those of you who don't know me, which should be a lot of you, because I don't pretend to be known more than a little bit. I grew up in Argentina. And at the age of 18, I moved to Los Angeles. Then, 2001, the country was going through a very bad financial situation. So I moved to Los Angeles. In Los Angeles, I became a dental technician. And my brother had moved at the same time to Spain. And he was a dental technician. Now, dental technology was nothing for me. I wasn't even thinking I'm going into the field. I like science. I like astrophysics. I like philosophy. I like all of those things, the wonders of the world. But I had to make a living in my new found city of Los Angeles with my newfound language, which I didn't speak any English at the time. And I became a dental technician. Once I became a dental technician, I worked in a lab for about a decade. In the meantime, I found who now is my wife, and we got married. And through that, we moved to Boston because I decided I wanted to become a dentist now. So I went to Harvard Dental School and I became a dentist. And then when I finished that, I said, I want to become a prosthodontist. So I moved to Chicago and I did 3 years of pro school. And by then I became a prosthodontist with training in dental technology. And I was 10 years of dental technician, 7 or 8 years of school. In the middle, I did a degree in biochemistry. So I became a biochemist in between before getting into dental school. So here I am, a dental technician, a biochemist, a dentist, a prosthodontist that moved back to Boston after Chicago with my wife. And at that point, 3 kids and an 8-month pregnant wife. And I joined one of my professors at Harvard who wanted me to join him and was waiting for me for those 3 years that I left. So when I graduated from Harvard, one of the professors said, I want you in my private practice and I'll wait for you. So I came back. I worked with him for 3 years. I learned a lot. And then I bought a practice in the city of Wayland, which is 20 minutes outside of Boston. Then I purchased 2 more practices around it and unified them. So I combined all the patients. I brought one of the dentists who I bought the practice with to work in my office. And 3 years ago, I began the process of building my own office. I bought a building and I demolished it. And when I posted that, other people got upset because they were demolishing dental chairs and they got upset. And then I built a new building that we opened about 6 months ago, where in the first floor, we have the classroom for my academy, an academy that I started with my wife about 7 years ago, teaching photography, teaching excision, tooth preparation, occlusion, provisionalization, impression techniques, we treat patients live. And now we have an academy on the first floor, and the second and third floor is my brand new clinic where I practice the days that I'm not flying around the world and doing conference and teaching and creating content. So that is the summary. And the Spain relationship that you mentioned is my brother moving to Spain, with his wife and then daughter, and now he has 3 kids. Made my parents follow him to be able to be with their grandkids. And that means that my brother, sister-in-law, nephews and nieces, my mom and dad are now living in Spain. I'm in Boston with my family, wife and 3 kids, and everybody else is in Argentina. So I have that connection with Spain that is very tight culturally. Obviously, my family lived there now for 20 years. My laboratory is there because my brother does a lot of the work and sends it to me. And the work that I don't do, because about 90% of my own porcelain work I do myself in the clinic. So I incorporated that in the clinic of being able to do most of the porcelain work that my own work required. And when it gets beyond my artistic and ceramics ability, or when it gets implant cases a little more complex, then I send that out. So that's the summary of where we are right now.
Let's start with the first question. When did you start with dental photography? I see you wrote a book, you're doing courses. So it's an important thing in your dental career. When did you start feeling that you should take more pictures and developing also the passion for this?
Somebody who likes to learn. I don't like to be doing anything that I don't know how it's done, at least at a good quality, not an excellent quality. Some of them I want it to be excellent, but I don't like to be mediocre at anything that I can improve. So I've always liked the arts. I always like history, the arts, philosophy. I like almost everything, right? But I'm not a good drawer, so I cannot draw paint. So I got inclined to video, picture editing as a way of expressing art. Writing was something that I was good at, coming up with ideas and generating a story and making an essay and things like that. But for about 15 to 20 years, maybe it's just about until this moment, I had to learn a new language. So now the limitation was, if I'm in the US, my ideas on paper were hard to explain because my English wasn't good enough. As an expression of art, since I cannot draw, photography was something that I got really inclined. So around somewhere, I would say 2008, 2009, I started playing with the idea of learning about photography. By the time I got into dental school in 2010, I understood that I wanted to apply it to my profession. So I was self-taught on all of that. At that point, dental photography itself hadn't really taken off. Of course, there were books about dental photography, but the artistic way, the way of making pictures look nicer, that wasn't there. That was brought upon a little bit by social media. I grew out in 2010, 2011 of getting my first few cameras, and my first son was born there. So I went into a French for about 3 years of learning everything about photography, using YouTube and self-taught and learning about lenses and cameras and everything to take pictures. And because I was a recent father, that was the medium. You have a kid and you start doing every single picture for the kid is amazing. And I did really good work on those years, like 2011 to 2014. Not as much as in dentistry, because we weren't doing nothing worse, like taking pictures of in dental school, a couple of feelings, maybe a crowd here and there. By the time I get to post residency now, we're talking about 2013, 2014. At that point, Instagram is kicking off, and I find myself in the best position ever to create something. So I made the conscious decision to start an Instagram account where, since what I was doing in residency was almost everything in dentistry, right? I was doing all the lab side of full mouth reconstruction plus the surgeries, and I knew how to take pictures. Now I can take pictures of the process, the preps, the provisional, the impressions, the before and after, the glazing, the porcelain, everything. And at that point, that idea was really kicking off. So the Instagram accounts were small, but those accounts, many Brazilian accounts, Europe came later to Instagram. But here, Brazilians and Venezuelans and some of us in the US were starting to play. We're making these beautiful pictures of preps, beautiful pictures of before and after. And that really captured the attention of everybody. So everybody started following these accounts that had amazing pictures. And most accounts and most dentists were narrow on what they could present. If they were cosmetic, they had before and afters and cosmetic things. If they were you get the idea. But I had the whole range because I had the lab side, I had the planning side, I had the surgical side, I had the delivery side. I have big case, small case, complex cases. So my account was showing a lot of different things with photography that was really good. Nobody in my department, nobody in UIC in Chicago was taking pretty pictures. So I told them how to buy softboxes and how to take pictures of different things on the table. And I trained my entire whoever wanted to learn as my colleagues that were residents at the time as my account started to grow. It got to a point that everybody wanted me, or everybody, people wanted to say, when are you going to do a course? When are you going to do a course? So I started the courses and I started teaching the course that forced me to do a lecture, that forced me to travel the United States teaching everybody. That led to the creation of the academy, which was an understanding after I was teaching all my colleagues photography, they wanted to learn dentistry. So I created the academy. I contacted Dr. Carlos de Carvalho and say, you want to do this? Do you want to start giving courses? And then we started giving courses, hands-on courses. They grew into being sold out and almost the number one sold out course in the United States for a couple of years. And then the pandemic hit and shift things around a little bit. So at some point I decided to write a book, and I wanted to write a book that was different than all other books. You and I talked about this a little bit. No special, no better, it's just different. I did not want a textbook. I understood something that maybe other people hadn't understood. Once we're in 2017, 2018, and Instagram accounts and dental photography just explode. Every dentist who was following felt like they needed now to learn this, for their practice, for their account. And I understood that most people who wanted to learn about dental photography, they're not necessarily liking photography. They actually feel it as a burden. Fuck, do I have to learn this now? So it's not the same when you want to learn something than when you have to learn something. So I wanted to make a book that was easy to read, quick and easy to read, very visual, and I didn't want it to feel like a textbook. I wasn't going to spend a chapter with 1,000,000 words in it. I wanted to let the picture speak. I wanted it to be beautiful so that you can keep flipping as you're learning. So it took me a long time to find quintessence to allow me to do it horizontal and landscape and not vertical. Like really, that was a big deal. To allow me to use very expensive paper, to have a very expensive printout and quality to the book. Those were two things that I had to put. And I had nothing to back up my claim that they should publish that for me. I was a first author. So if you come in with all these requests, you say you're going to sell all these books. I'm like, I think I'm going to sell it, but I don't want the quality. It has to be really big. So I wrote the book. We put it in a very expensive paper. We put it in a way that was landscape. And I added what at the time was a chapter on social media and for clinics and SEO and Google and things like that. I partnered with Webistry for that, which is a company that does advertising for dental offices. And that book became the number one dental book sold in North America in 2019, being a photography book. And it did really well in many other countries. And that was my journey to photography. Also, I understood it from the side of a technician. I've been on both sides, sending information and receiving information. So that also helped clarify several things. And I wrote the book for dentists and for technicians. There's a chapter for technicians specifically. So that's the journey with photography that I have.
That's amazing, especially that you taught yourself. But I always tell people dental photography is not a secret or not a book with 7 seals. A lot of people are struggling because they don't start. They come and ask me questions like, how can I take pictures like this guy, or how can I take pictures like that? And I tell them, look, first thing before thinking of doing this social media style images, think about becoming a better dentist. So basically, for me, photography first is clinical documentation. I compare it always as X-rays. So we have X-rays to look through our patients, and we have photography, videography, scanning to look at our patients to get the overall image, to plan our treatments. And I see that too many people are not really understanding the role, let's say the number one role of dental photography, and are only focusing on the artistic part. You see it also when you see the courses and workshops, especially from the guys from South America. traveling around the globe and talking about the art of dental photography. For me, dental photography has nothing to do with art. It's technical. I remember a story with Nikon many years ago. They told me, look, with the digital cameras that started 1999, I was one of the first having a Nikon D1 camera, so 25 years ago. And then everybody wanted to become a photographer because it was so easy to shoot and you didn't have to wait for the images. So it was immediate. And they were telling me, look, photography, not dental photography, has a very high technical part. So let's say 95% of photography is understanding how the camera works, what the lens is, so technical parameters. And then they told me, we can show you how to take a nice fashion photo. We can show you how to take a nice landscape photo. But then there's this 2%, 1% creativity that comes into play to separate you from the rest. This is then the artwork of like patients I have that are famous fashion photographers. And then you always think, what is different? What is different? How they look at something, how they capture something. But in dental photography, there's no artwork. It's like when you do an X-ray, you have the X-ray holder, and in a certain angle, you have to shoot to get all the information on the film. And the same for dental photography. You have the portraits, you need to see the eyes, you need to have the patient position, you need to see all the landmarks. The same with our teeth, with everything. So the clinical documentation should be 95% or 99% of what we are doing without losing too much time. You don't take 20 X-rays, or you don't put a soft box on your X-ray machine to have fancy X-rays. You want to come straight to the point, be efficient in what you're doing. And if you have time, if you finish early with your patient, you might get into creative photography. So basically, what are your thoughts about this?
I have a lot of thoughts about what you say, and I'm a pusher, so I'm going to push back a little bit on that. I think what you're describing is the definition of what dental photography is. If you put dental photography and you define it as the photography that we take to record things, to communicate between other dentists, clinical dental photography for the patient's record, and for like ortho, what they do, right? Always the same set of pictures, always the same set of pictures. If that is what dental photography is for you within a dentist's office to record what it is and to communicate with other dentists, or to communicate maybe with an audience if you're teaching, then you might be right. It's very systematic, and it should be systematic because we need to standardize it to communicate with each other. But if you expand the definition of dental photography to taking pictures that are related to the mouth, then there is a very large landscape and room for artistic photography. So in my book, and I think this being one of the reasons that it sold and it continues to sell so well, it's aging very well, to be honest, is that I taught people how to do the intraoral and extraoral protocol. That's what the book is called, LIT, a guide for intraoral quick. I don't remember the title of my book, but it's simple intraoral protocol for dental photography. Okay, simple intraoral protocol for dental photography. The reason the book is called like that is because I teach you how to take a full set of intraoral pictures with less than 7 minutes. Right? You should be able to do it after you do it about 20 times. And when people come to my courses and see me, I teach them live how I can take all the pictures that they always struggle with within 5 to 7 minutes, because that's how it should be in a dental office. You can't be spending 20 hours in a new patient taking pictures. That's very palpable. You can see it. But then I also have a chapter in which say, okay, listen, if you want to take what is called artistic dental photography, then you need to understand chromaticity, then you need to understand light, and you need to understand texture, and you need to understand contrast. And I teach all of that on how to take those pictures as well. So I don't think you're wrong because how you define it. You had another question among in there that I need to answer. Dental photography grew in interest as social media, especially Instagram, grew. And eventually it became that a lot of people learned, and we now gotten tired of the pretty picture. It doesn't really give us anything. So when it came to about 20, 18, when everybody was doing shows, my account had become big, some other accounts had become big, and many people wanted to now become big by posting pictures of their treatment. What I understood is that I understood two things. I understood that we were lying to our colleagues of showing always pretty things and pretty afters and pretty results and pretty everything, using diffusers to mask many things. So I switched. I was one of the first one, if not the first ones, to switch my account to literature reviews and talking about treatments and controversies. We're using pictures and things to always discuss. And I moved away from posting pretty pictures. And that was a change that many people follow where we are today, which many accounts that are big are basically teaching you, like mine, like we were talking about Marcus Blatt, Valentin Antonio, yours in the area of photography and other areas as well. So that was, to me, the result of people now getting tired of seeing pretty pictures. So now the value of the pretty picture came down. And now we're going into the area of pictures can be made by AI. It's not really good in dentistry yet, but like we're moving away. We're even creating things is now, and content with value is what matters. I believe that people thought at one point that they needed dental photography to create a bigger social media presence. But what you were thinking about, and what I find very interesting, is photography to me did many things. Photography to me is the number one critical tool for my own dentistry. When you look at a pretty dentistry for somebody else, and when you think that you're also doing pretty good dentistry, and then you document every step, then you realize who you really are. You can't lie with the picture in front of you, showing the management of the tissue, showing the preparation, showing the final result of the case before and after. So if you really want to get better, you better get good at photography and take pictures of your cases and compare it to others. Man, it's going to be humbling at a deep core level. So to me, it was one of the best pusher towards growth. The second one being teaching. One of the reasons I teach, especially dentistry, is because I cannot go in front of an audience. We don't know what the heck I'm talking about. That's just not my personality. So if I'm going to be teaching you this, I better know everything about it. So when I teach, I read every single paper about every single topic, tooth preparation, adhesion, implant communication, materials, impressions, provisional extension, whatever in dentistry occlusion. It forces me to know, because if I'm going to go in front of 20, 30 colleagues, they're going to prompt me, and they deserve, since they pay a lot of money to come see me, they deserve for me to do my job, to know what I'm talking about and to know what I don't know, so I can say I don't know to a question that I've been asked. So photography and teaching are what made me, and I know this, a better dentistry every day, a better dentist every day.
No, reading is something that a lot of our colleagues are a little bit missing out, and they always find excuses. So that's not only in dentistry, it's also in medicine.
Human
That,
nature.
for example, our son told me that oncologists, they should read a lot because it's a topic
I can see that.
that is developing very fast. And the average oncologist in Switzerland is reading 3 papers per year. So this is ridiculous. You should read more. And if you ask dentists, and if they're honest, they are not reading that, so not
Very
so
little.
much. So basically, the majority of dentists rely on people like you or others, teachers. So basically, if we talk about evidence-based dentistry, even if you are well prepared, you're not on top of the level of evidence. But this is interesting. This is an interesting topic, and for me also a fact why dentistry is moving relatively slow. For example, this year we are celebrating 40 years CEREC. 40 years ago, I was a student when Professor Merman at the university presented us the CEREC technology. In 1986, I got 5 inlays done from Mark Hürzeler with the prototype of the CEREC machine. I still have them in my mouth. 1986, so that's 38 years now. They're still in my mouth. They don't look good, but they are still there, and I keep them as a long-term clinical trial.
So cool.
And
what was the material?
But
Mark 1? What was the material? Mark 1? What's the material?
Mark 1, yes, that's Mark 1. But they were different. So I think 3 were Mark 1 and 2 were other experimental ceramics. So nobody really knows what bonding materials, what material. So he took everything that was just like just that was
Yep.
there. You know what I mean? Different bonding protocols, different materials. He was just playing around with the machine, and I was like the guinea pig. I was a dental student with some small amalgam filling that had to be replaced, and he was saying, "Hey, come on!" And we worked. We did for the 5 inlays. It took us 2 days, 15 hours, so 8 and 7 hours to do 5 inlays. 15 hours. That today we are much faster. So there has been a development. But I would like to ask you, why has digital dentistry not evolved more over the last 40 years? So why are still a lot of dentists completely analog or still thinking, yeah, I don't believe that these computers are really reliable? Although I guess that the majority of students learn what a scanner is and how to use a scanner. Or am I completely wrong that the education is not at the level we need to get more people adopting these new technologies? Or what are your thoughts on this still for me a little gap that we not even have reached or hardly have reached 50% of dentists around the globe using intraoral scanners or other digital tools?
To answer that question, we're going to have to separate and what I think is responsibly to do two different subset of dentists. The ones that can have access to the technology and the ones that cannot have access to the technology, right? Obviously, there's a lot of places in the world that they just cannot have access to the technology. Okay. So let's put those aside for a second. Let's go the ones who can. And from those who can, those who adopted it and those who don't, that will be, let's explore that subset. So from those who can, which usually are the developed countries, Europe, North America, Australia, Japan, all the countries that have the means, the Middle East, they have the means to have this technology that they can buy it and use it, but decide not to. And I'm including the ones that think it's too expensive, but the country many of their colleagues have it. I'm including those. Okay? From those people, I truly believe is complete lack of understanding of what digital dentistry means and what it can do for the patient. They still see it as an option, and I don't see it as an option. I see it as a standard of care. Why do I say that? Because the technology of being digital, when you couple it with same-day dentistry in your clinic, with having a milling machine, not just the scanning. So a lot of people are confused with digitally scanning and planning, okay, WhatsApps and analyzing the patient on the computer. No. To me, the circle completes when you can mill the restoration and the patient is sitting on the chair. And when that was first, and I'm going to explain why in a second, but when that was first introduced, the generation of dentists who first tried it, let's be honest, early 2000s when it really took off with IMAX. So even though it started in 80 something, like you say. So when IMAX comes along and when that technology of milling the restorations in your office is available, and now you can dispense with metal crowns or PFM crowns, the dentists that were doing that were in their 40s, 50s, and 60s. They were trained in the 60s, 70s, and 80s, and retention and resistance was king. And cementing was not adhesive, it was just luting. And when they tried to use this machine, first of all, super expensive. Second, they supposedly didn't like how it looked. Stupid. Three, it used to break. And the breakage of this, so they claim, you change failures, you back away from it, you talk shit about it. That was a cycle that I saw because I was in the laboratory in the early 2000s and I saw that happening. Dentists who will say that IMAX was not a good material and that the margins weren't good and that they break and things like that. And the reality was that they didn't know how to prep and they were not bonded. Now we know that ceramics need to be bonded, and it's part of the adhesive bonding that creates the strength of that complex ceramic bonding, restoration, and tooth. So now we know that it's not an issue. We can completely disperse the metal, and we have companies who are given all these ceramics. So when you have the digital and when you have the milling capability, now you don't need a temporary. And when you don't need a temporary, and when you understand the science of play, you understand that retention resistance is not needed anymore. And when you understand that retention resistance is not needed anymore, now you can do faster, better, more conservative dentistry, same day that the patient loves. It increases your revenue. It makes everything much simpler, but they don't see it like that. They haven't understand that's what it is, that it is better dentistry for the patient. Oh no, but it doesn't look like afterwards. When the meal sticks, it's all blended and rounded. You can modify it. It takes 2 seconds to get a burr and modify the restoration between you fire or before you polish it. So these excuses are reverberated over time because they were the first excuses that the previous generation of dentists exploded by their own inability to understand that they needed to prep different and they needed to learn adhesion. So now when you learn adhesion and when you understand that this leads to a better dentistry, a better long-term tooth survival, because you're being more conservative, because you can do little tiny things, time off, and not everything has to be a PFM crown, is what they don't understand. And they continue to see, oh, I've been doing it this way. I don't need to. Oh, I don't have time to finish my own restoration. Oh, I don't have time to do this. I'm going to send it to the laboratory. So I think it's the lack of.
But then, yeah, but then there's also lack of understanding in the people teaching, because so the generation, the teachers, because I think the change starts with education. And if the education is not really telling the young generation, look, the way you explained it, this was the lecture in 1985. Professor Murray was telling, imagine the machine, you, the patient, working together. So Chairside Dentistry was born in 1985. And I started in 1990 with my own office. And I started with 2 CEREC 1 machines, and I tried to do as much as possible at the chairside. And a lot of people, even when I talked with Nazari, he was telling me, yeah, but can you do a full mouth rehabilitation at the chairside? And I told him, all the yes. Time. Because he was like asking me, but would you do a full mouth rehabilitation at the chairside? And yes. I was telling him, yes, I'm doing it for 30 years. I'm doing it because it's, for me, the best way to treat the patient is when you have the patient in front of you and not sending around things and doing temporaries and waiting. And then you get all the stories of what steps you need, additional steps that for me are, so if you cut fresh dentin, you bond to fresh dentin, you don't have to care about pollutions or contaminations or all this stuff. And I don't understand that we are overcomplicating a lot of things in dentistry, and we could make it much more effortless, easier. So basically, I listen to you and I hear that you completely agree with.
It's surprising to me how controversial it sounds to do a full mouth reconstruction in a day or in 2 days. And I've been doing it for several years now, and I publish papers on it, and I teach it. That is it. And every time I teach it, I get the audience, especially if they are prosthodontists in the audience, especially if they are about 45 years old, their eyes roll, they make funny comments, they fight how to make a full mouth reconstruction. You have to do all these steps. And it is surprising to me the lack of awareness of why they do what they do. They forget the why of the steps, and the step becomes mandatory in their mind. And they don't understand that each step has maybe a good reason why you're doing it and negatives that come from that step. To me, the provisionalization step is nothing but a negative to the state of the dentition of the patient. Prosthodontists have glorified the provisionalization stage out of their own lack of ability to prepare the case correctly, to transfer the wax up into the mouth correctly, to take a good CR, and all of those steps. But in my clinics, for example, you come to my clinic and you need a full mouth reconstruction. Let's say you have a bunch of teeth and they're all broken, whatever. You need a full mouth reconstruction. Every tooth needs a restoration, or almost every tooth needs a restoration. I will take all the records, including CR, and I will send that to the laboratory, and they will do a wax up. And then when the patient comes, the next appointment, this could be the second appointment, let's say, if he agreed to treatment in the first appointment, I will put the mock-up in the patient's mouth. I will transfer it with a putty. And at that point, I will get, let's say, the upper arch, and with the mock-up, upper and lower in the mouth, now I can check my centric, my CR, my lateral movements, my aesthetics, my phonetic, the facial analysis, everything. Why? Because it's there. I use pictures and the records together there. Now I confirm. I can modify it, I can add, I can reduce. I can tell the patient if they like it, the length, the width, the shape, how does he feel to everything. Now, here comes the first thing the prosthodontists or many general dentists will say. You cannot do a full body reconstruction without testing the video of the the patient first. This is what they say. You cannot do a full body reconstruction without testing the video of the patient first. The patient needs to use a temporary to see if they can adapt, to see if this, that. That's not true. There's this published literature and there is a consensus statement that is about to be published that we generated in Madrid together with the Society of Restorative Dentists of your country, Switzerland, separate, which is the Prosthodontic Association of Spain, and ProSec, which is an organization that I am part of. We all met in Madrid, and there's a paper coming out that review everything about video and the need to do any step prior to a full body reconstruction for a patient to adapt. Zero evidence that you need a spleen or 2 months to see if they adapt. Zero evidence. You don't need it. So you don't need that. So the patient likes it, you like it, the occlusion is how you want it, the length, everything is good. Now I'm going to prep that arch, minimally invasive, how I prep my teeth. Now I'm going to do all my bonding protocol, immediate dental sealing at the spot. Now I'm going to scan again, and I'm going to merge the design with my scan, and I'm going to start milling the final restoration. And I'm going to deliver the final restorations the same day. Yes, that requires that you know how to finish restorations. That requires that maybe you're going to need a technician or site if you don't want to finish it yourself. It requires other things to learn. It requires being familiar with the protocol. It requires you knowing what the heck you're doing, whatever. But that is the right thing to do, because the other option, I know how it is. I've been taught of it, and I've done it. You need to prep the entire mouth. You need to provisionalize. Don't tell me that you're going to provisionalize tooth by tooth. You're going to make big bridges span of your provisional. Now, those provisional has to draw in and out. So now you're cutting more tooth so that your provisional draw in and out, because you're doing 5 at a time, or some people do the whole arch, and it has to sit in and out. So I know that you did with every tooth, you did this, okay? Most of them are not doing immediate dental sealing. They're going to get all that dentin that is exposed and over hot because you don't need it to do that. You put your temporaries in, and now you put your 10 bone on top of this dentin. The collagen is going to denature, bacteria is going to get underneath. By the time you took the impression and come back and I tried to deliver this, you're going to deliver all these restorations on top of all the dentin that is denature, destroy, bastardized. And because you deliver now beautiful 12 restorations that a lab did, you think you did a great job. It looks great. The bite is great. The patient is happy. But the problem is most restorations don't fail because they break. They fail by secondary decay. They fail by infiltration. They fail by the hybrid layer, denaturing and hydrolyzing over time. And your way of doing it that way, it was the worst for that. This lack of understanding of what a provisional does, or what the steps were meant for, or what the BDO is what is keeping dentists in this idea that they have to do all the steps. And to me, is I rewire myself and I say, hold on a second. What's more important, my restoration or the tooth of the patient? What's more important, my pretty perfect cleaning guidance, which I go for almost every time that I do a full body restoration, or no, every time, or the fact that this restoration lasts 15 years without decay instead of 7 years and it starts getting infiltration and decay. I think that's where it resides.
So we need to be advocates for more chairside dentistry around the globe. But I think there's also a lot of politics related to what to do and what not to do. Coming back again, societies, universities, teaching philosophies. And I experienced over the years also being editor-in-chief of the International Journal of Aesthetic Dentistry, a lot of controversy, especially, for example, when I published 3 articles, the 3-step technique by Vailati and Belzer. You cannot imagine how much opposition there was from the prosthodontic, especially from the Italian, from the IOP, how much controversy. You cannot publish this, is not correct, or the bopped technique by Ignazio Loi. So a lot of good ideas are sometimes then tried to being eliminated or pushed out or banned. And this is interesting that a lot of development is blocked by politics in dentistry. But again, thank you for this again, somebody who's an advocate for chairside dentistry, because you don't find many around the globe. And I felt that also with Nazari, who is a great dentist and teaching, and wow, he's really perfect. His work is perfect. But I felt that he would not do a full mouth case at the chairside. And even experience, he's a well-trained dentist, and I'm sure he could do, but he doesn't want to.
I
So this is something the point
I have
also.
come to have extensive, heated debates with the great majority of the dental speakers and educators of the world. There is a place in which most of us who teach dentistry around the world, the ones who all the speakers that you see on the podiums all the time, all over the world, we are interconnected in a WhatsApp group. And you will be surprised to know that I was one of the lonely voices arguing for days and with great intentions and backing it up with science, making the argument that crowns have no indications in dentistry. So there is not an indication for a crown being a full cover restoration all the way to the gum, right? All around. That's the crown that I'm talking about. And no matter how much science you put, no matter how many arguments you make about how retention resistant is not needed anymore, therefore there's never a need to cut all the tooth just to hold the crown in place, and that there are no indication. Very prominent president of associations, president of the big congresses and things like that, all the big speakers of the world were infuriated by not only the manner in which I presented the argument, which I find ridiculous that people get upset about the manner in which you behave in an argument instead of the content of the argument. I would say even today, 90% of the big names in dentistry still believe that there is room for a crown in dentistry, that there's an indication for it. When to me, it's very clear because of the science and the common sense of it all, that the only time that you need a crown, the only time that you have a tooth that has a bunch of enamel and you're going to decide to remove it all to cover it around, is the only chance you need to cover the whole tooth around is because somebody else already did a crown. There is a new replacement. There is a small argument, not small, there's a valid argument for some cases of melogenesis imperfecta and things like that, that the whole tooth is already messed up and the whole enamel is already messed up. There's an argument there. Although you need to ask, you still need to remove the bad enamel that is there. Is the bad enamel flicking off in that type of AI, or is this just bad enamel that I can still bond and it's still better than bonding to dentin? There's still an argument to be done there. Most people around the world still think that a tooth needs to be reinforced by a crown, that you surrounding the crown with any material, the tooth will reinforce it. Like when you do an endo, you need to reinforce it with a crown. No, there's nothing that you're going to do to reinforce a tooth. There is no tooth reinforcing technique in dentistry. There is a tooth that had some problems, some issues, some defect, call it breakage, cracks, decay, and you find the structure to be compromised and some of them be denature and decay. You need to remove that, and whatever is left of whatever shape and as much enamel as you have possible, you need to leave. And from then on, you need to excessively add the restoration to reconstruct that tooth. And that is at the level of the single tooth as much as at the level of the full mouth reconstruction. Occlusion should not trump single tooth dentistry. You don't get to say that because you need to get a hold of your occlusion, that now you need to put crowns all over. That is a fallacy that is doing harm to the patient. Because occlusion, as important as it is also a bunch of ideas that are hard to prove. And what is not hard to prove is the secondary decay will come, and that the more enamel that you remove, the shorter the life of that tooth. And our job is for those teeth in the mouth to last as long as possible. So to me, every time I make this argument about no temporary, about adhesion, about no cutting enamel, when I do it even within the circle of the most famous speakers of the world, they get pissed. They get dogmatic. They start talking about how you don't know what you're talking about. I've been doing this for so long. I've been seeing so many failures. And that's such a failure of an argument. I've been doing this for so long and it's been working. What does it mean that it's been working? If I'm telling you that there is proof that it can be done better, is your way working if it can be done better, right? If you achieve X success, but there is a way of achieving 20% more success. Is your X, which was the best 10 years ago, still a success today? I think that the failure of recognizing that is what keeping our profession behind.
This is a great closing remark for this episode. But Miguel, we need to continue our discussion because there's so many things that I would love to talk about. One big topic we need to address would be minimal invasive dentistry. One of these odd words. Everything is minimal invasive these days. Even placing implants is minimal invasive. Before you place an implant, you need to be maximal invasive to remove a tooth, and then and so on. So I think there's so many things we need to talk about. But thank you very much for the two insights on dental photography documentation being not only a clinical thing, but also a little bit artistic work, and the fact that chairside dentistry is alive and something that we need to push further. I know many chairside dentists around the world that maybe they should raise their voices more and fight a little bit against the establishment, would call it the establishment. And together we can spread the word, continue what you are doing. And even if sometimes chairside dentists around the world, that maybe they should raise their voices more and fight a little bit against the establishment, would call it the establishment. And together we can spread the word, continue what you are doing. And even if sometimes it's controversial because there's not the truth, there's so many different strategies. As we say, all the roads lead to Rome. You could say many roads lead to Rome. Many ways lead to the same result. And I think be open-minded, listen to others. And what you perfectly stated as at the end was, a lot of people are saying, "Oh, I do this for many years and it works." And this was a perfect statement from your side. Yeah, maybe you did 30 years, you did it wrong. It worked, but it could be better. So this was the perfect statement. Never think that you could not improve yourself, improve the work for your patients. Read more, listen more, discuss more, because this is the exchange of information is something that I see is still missing in the dental community. Sometimes people talk to each other, but don't listen to each other. Thank you very much, Miguel, for this first part of our interview. And we will definitely come back for more content to talk about. Stay tuned and talk
Thank you,
to you
Alex.
soon.